Hello, students. Welcome to the third and final section of GI Patho. I hope you're enjoying this series. So today we'll talk about diseases that involve the colon. Largely, we'll talk about the appendix, appendicitis. And there's the ascending colon, the right hepatic flexure, transverse colon, descending colon, and then finally the rectum. The large intestine is 1 to 2 meters in length, largely concentrates and stores GI content. There's a rich bacteria that live in the bowel, also contribute to digestion of food and toxins. Up to 5 liters a day of water can be reabsorbed through those aldosterone receptors in the lower colon. And then, of course, the other function of the rectum is defecation. So large bowel diseases we'll look at here are diarrhea, constipation, Crohn's disease, ulcerative colitis, diverticulitis, and actually I added celiac disease. So diarrhea, obviously I think everybody thinks they understand diarrhea, but remember what's diarrhea and what's constipation for one person could be very different for others. Diarrhea is defined as excess stool fluidity, so increased volume or increased frequency. And when we talk about diarrhea and gastrointestinal dysfunction, we have to think, is it osmotic diarrhea, secretory diarrhea, or motility issues? Because the treatments for each will be a little bit different. Most often we have problems with secretory and or motility, but you can have some osmotic diarrhea. That's actually one of the number one reasons that people, the most important one is secretory and motility. Secretory, form of large volume diarrhea caused by excessive mucosal secretion of chloride bicarbonate-rich fluid, which ends up with an inhibition of net sodium absorption. And motility is excess motility, which decreases transit time, mucosal surface content, and opportunities for fluid absorption. And then another classification is acute diarrhea or chronic diarrhea. Acute diarrhea is less than 2 to 3 weeks. And these are all the conditions that are classified under acute diarrhea. Should always treat diarrhea as acute until proven otherwise. And then chronic diarrhea is greater than 4 weeks, and that's more of your bowel diseases that we'll talk about today, such as irritable bowel syndrome, inflammatory bowel disease. We won't talk about parasitics and fungals. And I just threw in COVID here too, because COVID, anytime people have diarrhea, has been diarrhea. I think it's like the 4th commonest presentation of COVID is diarrhea, so something to think about. Diagnostics for diarrhea, good history really will tell you a lot. Then collection of stool samples, looking for the presence of leukocytes. It helps to sort out, is this an inflammatory diarrhea or a non-inflammatory diarrhea? And I've listed the factors here that are inflammatory and then the ones that are non-inflammatory. And then, of course, look for fever, look for elevations in WBC count, and check the Chem 7 because the sodium, potassium, and bicarb could be off. And definitely, if the history tells that patients have been on antibiotics for a long period of time, they should definitely be screened for Clostridium difficile. Constipation, again, what's constipation for one person, really it could be something totally different for another person. But we define, I think that it's not here, but typically we think about less than 3 bowel movements a week is typically, I think, how we define it. But it's basically decreased motility in the colon and retention of the feces in the lower colon or rectum due to suppression of the urge to defecate. And disorders are multifactorial. They're diseases such as endocrine and neurological diseases, particularly diabetes, can cause, with neuropathy, can cause problems with constipation, hypothyroidism, some of your upper motor neuron diseases such as multiple sclerosis and Parkinson's disease can contribute to decreased urge or defecation. Many medications, namely opioids, any of the aluminum like milk of magnesia, calcium channel blockers, have been quite extensively been linked to constipation. Think about your anticholinergics, right? Because the parasympathetic nervous system innervates the GI tract, right? Increases secretions. So if you block that with anticholinergics, You're going to get constipation, absolutely, without a doubt. Dietary factors, many of these are attributed to lack of fiber in our Western civilized diet, or maybe it's not so civilized diet, and lack of exercise. Appendicitis, right lower quadrant pain. It's a leftover organ from evolution, so it doesn't have any functional value now, but just can be very problematic at times if a stone, what known as a fecalith, gets caught in that little duct there, just proximal to the appendix, then it can cause inflammation and appendicitis. Yeah, I've just said that. You need to act quickly because in 24 to 36 hours, necrosis can set in and then you can end up with peritonitis. So, this is abdominal pain that comes in waves. Pain starts in the epigastric or umbilical region and then it becomes localized in the right lower quadrant. And that point is called McBurney's point, and I've got a picture of it here for you, so you should be familiar with that. And then finally, anorexia, nausea, vomiting, fever, and WBCs become elevated. Patients have what's known as rebound tenderness. When you press in, it actually it feels better when you actually, after pressing in and then releasing, the pain actually feels better. Pain on right lower quadrant and pain in their right lower quadrant. And then there's the psoas sign, which will tell you that it confirms that the appendix is swollen because you have these musculature areas of musculature in the hip. So if you extend the leg, or as you can see here, pick up the knee on passive movements, if they have pain, then that means that the appendix is swollen retroperitoneally, and that's a sign that for action. So diagnosis is made on physical exam, as I just showed you, lab, or possibly an ultrasound, NPO, IVs, and basically surgery. And same day surgery today. Diverticular disease, very common now, unfortunately, it's a disease of Western civilized countries, largely because we have low fiber diets and lack of exercise. In the 1850s, our brains were becoming less fiber in our brains with refinement, and now we're just not eating the fiber that we should be eating. And the aging population, so it contributes to diverticular disease. You should know what diverticulum is, diverticulosis, and diverticulitis. Okay, so diverticulum is the sac-like outpouching, and diverticulosis is the presence of those diverticula. But then they become infected, and that actually is the pathology associated with disease. So here you have outpouching of that submucosal tract, and that causes an increase in pressure. And if something gets like a legume, remember legumes, or seeds or anything are often culprits for blockage of this diverticulum, which then leads to diverticulitis. Sorry. So here's a diverticula. That's not uncommon that you see that. I have a few from my colonoscopy. But then, of course, if something gets stuck and they get inflamed, then you have diverticulitis. Here's again another picture of diverticular disease. So symptoms include pain in the left lower quadrant with low-grade fever. Very common in nursing homes, and patients don't present very well. Sometimes they'll just tell you they're constipated, but they might not even have some of the acute signs and symptoms associated with the inflammation, right? Seniors and elders have blunted immune responses. So very commonly, you won't know that they have diverticulitis until you actually probe and do a belly exam and then find that they have pain in their left lower quadrant. They may or may not have rebound tenderness depending on the acuity of the diverticulitis, but they will have nausea, vomiting, abdominal distension, maybe some bloody stools. And if not treated, this can actually lead to peritonitis and septicemia and even lower GI bleed. So the medical management really is bowel rest. you can treat this in the outpatient setting by just having bowel rest, means just liquids, enough liquids to keep up with hydration. But if it's truly pronounced, they have fever, left lower quadrant pain, they might need to, and elder, they might need to come in and then be put on IV fluids and antibiotics, and certainly NPO. Um, do we want to give these people anticholinergics? No, no, you don't want to give these patients anticholinergics because they're not good for GI disease, right? Symptoms subside within 48 to 72 hours, and usually people just start back with a low residue or low fiber diet until the bowel is well healed, and then the treatment is fiber in their diet. Two other lower colon diseases, IBS and IBD, irritable bowel syndrome and infectious bowel diseases. Irritable bowel syndrome is, for some reason, particularly females, particularly young females, they have this visceral hypersensitivity. So their tolerance for pain in the gut is much lower than most people. And so they constantly feel like their bowels, that they have pain, that the bowel is ready to, constantly moving and uncomfortable feeling. But there's no structural or biochemical alterations. They may also have some overgrowth of intestinal flora. Food allergies can also be related to this. And largely we looked at this disease before we realized that they had this visceral hypersensitivity as psychosocial factors. And indeed, stress can make it worse. So do look at that as a cause for irritable bowel syndrome. There's two types. Some patients are diarrhea predominant, and some people are constipation predominant. So really, the clinical manifestations are lower abdominal pain, gas, bloating, and nausea. And the treatment, there's no available cure because some of this, there's no structural problems associated with this. There's just this visceral hyperactivity. So sometimes low dose antidepressants and serotonin antagonists or agonists can help. But prebiotics might help establish growth of the healthy gut bacteria, and probiotics such as peppermint oil, hypnosis, and psychotherapy may be helpful for these patients. Now, the inflammatory bowel diseases, there's two forms. There's Crohn's disease, otherwise known as regional enteritis, and then there's ulcerative colitis, and you need to know the difference between the two. So I've given you a chart here. Most importantly, Crohn's disease can be anywhere in the lower colon. Sometimes maybe even in the smaller intestine, but largely in the entire large bowel. And they have these skip lesions. They have little patchy areas of disease. And then ulcerative colitis is just that. It's ulcerative. It's ulcerative. And it's just in the lower descending bowel and rectum. And again, here's another chart, just showing you the difference between ulcerative colitis and Crohn's disease. So the Crohn's disease can be the entire intestinal wall, and with ulcerative colitis, it's just the outside or the mucosal layer. It doesn't transcend beyond that mucosal layer. But with Crohn's disease, it can infect the entire thickness of the bowel wall. You get these cobblestone appearances with this patchy disease. And it's not as common to have bloody stools with this Crohn's disease. It's very common to have bloody stools, as you'll see in a minute, bloody stools with ulcerative colitis. So learn the difference between the two. Again, here's Crohn's disease. You've got full luminal degradation associated with that inflammation of Crohn's disease. Here with ulcerative colitis, it really is just the mucosal lining. And the red rawness that you can see here lends itself very nicely with ulcerative colitis for bleeding in the stool. And it's usually the entire mucosa is inflamed, as you can see here. whereas with the Crohn's disease, it's sort of these spotty problems. In Crohn's disease, there's no known cause. It tends to be familial, and as I already told you, parts of the bowel that's involved. There are these Peyer's patches, which are oval, elevated patches of lymph follicles sometimes on the small intestine, and skip lesions throughout the bowel. Otherwise, they give it a sort of a cobblestone appearance. These Peyer's patches are actually sites where the intestinal macrophages are sort of concentrated. So as a result of the inflammation, you end up with these Peyer's patches, which are commonly seen in colonoscopies in patients with Crohn's disease. And Crohn's disease is chronic, and it leads to colonic obstruction, which usually means parts of the bowel have to be removed because it will lead to stenosis, perforation, and fistulas are not uncommon with this disease. In early manifestations, it does closely resemble appendicitis. Pain is usually dependent on the area involved. If the ileum is involved, they have vitamin B12 anemia. They may also have folic acid anemia, vitamin D deficiencies, and calcium deficiencies. Steatoduria is present if the inflammation extends into the small intestine, but not as common if it's just in the large intestine. And that's fatty stools, which actually float. You can see that after they've moved their bowels. Okay. Here's a picture of Crohn's disease. See the patchy segmental cobblestone appearance? Very common with patients with Crohn's disease. So complications include perianal disease and fistula formation, very not uncommon. Enterocutaneous fistulas between the bowel and the skin are most common. I've got a picture of it here. Loops of bowel, just kind of because of infection, sort of come looped together, and then you can create these fistulas. And these fistulas can actually perforate and then actually leak out onto the skin. You also have lots of strictures with Crohn's disease, which causes, obviously, obstruction. Now, ulcerative colitis is, just as I said, it's ulcerative, it's a mucosal layer, it involves the colon and the rectum only. Increased risk of bloody mucousy stools. It can be autoimmune, it can be genetic as a result of allergies, it can come on as a result of viral or bacterial infections, and lesser emotional stress. Risk factors are Jewish, white, family history. Bloody diarrhea and abdominal pain is a classic symptom, with left-sided abdominal pain because it involves the last part of the colon, which is on the left. Severe diarrhea, dehydration, hyponatremia, hypokalemia, loss of bicarbonate, and calcium loss can ensue. Diagnosis is a sigmoidoscopy. Is all that you need to do to confirm it, because you can see that inflamed mucosa. We don't do barometers like we used to, but if you did, you'd see loss of that bowel haustra and ulceration. Labs, obviously these patients might be anemic if they lost a lot of blood. They may also have low albumin and hypokalemia. Complications can include toxic megacolon, which can lead to peritonitis. So that would require bowel rest, NG tubes, IV fluids, corticosteroids, antibiotics, and surgery. And here's the difference. Here's ulcerative colitis. Red, raw, hamburger-like appearance. Crohn's disease, pale, cobblestony, patchy. And then I just wanted to mention celiac disease. It affects apparently 3 million people in the United States. It can affect all ages. There's no cure, but 100% gluten-free diet can reverse many of the effects of celiac disease. Obviously, they're allergic to gluten, so they need to cut back entirely 100% on gluten. And some of these patients are lactose intolerance can be present in 50% of the patients. And a lot of this actually is genetically inclined. It can affect IDDM, type 1 diabetics, higher incidence in patients with Down syndrome, and people with already have vitamin deficiencies such as B12 folate deficiency are at higher risk for celiac disease. And here's the normal villi in the small intestine, and here it is with as a result of celiac disease, these flattened villi, so they have lots of less surface area for absorption of all the various nutrients. So here's all the symptoms associated with celiac disease. Particularly look down here at your vitamin deficiencies: low iron, low calcium, low vitamin B12, low vitamin D. And as we've talked about over and over again during the semester, anytime you have high incidences of inflammation, over time you increase the risk for cancer, right? So these patients are at risk for any type of bowel cancer. And then lastly, peritonitis. An ulcer can perforate bowel, any part of the lower bowel can perforate, which leads to leakage of the GI contents into the peritoneal cavity. And then the peritoneal cavity is a rich source of capillaries. So these gram-negative bacteria gain access to the bloodstream, and it's a medical emergency. Peritonitis is board-like rigidity. Bowel sounds go silent. Rebound tenderness. Pain is lessened upon palpation and magnified upon release. Pain often goes away as the intestine actually perforates. That's a bad sign. When the patient has had signs of peritonitis and then says, "Oh, I feel better now," that's a very ominous sign. So I'm leaving you with this lovely picture of, I think it's a chicken pot pie. I don't know why, I just needed to do that. I hope you've enjoyed this podcast, and I'll see you in class next week. Thank you very much.